As we continue on, we'll have two sets of three panelists. I'm going to do very brief introductions. Any one of these people, and then the three to follow afterward, are people about which I could say a great deal, and it would all be wonderfully positive, and it would be what you would call accolades, because each of them in their own domain has generated information, has connections, and made connections that help bring one set of information together with the next set so that we have indeed a whole set that helps move us forward. But in spite of that, I'm nonetheless going to be brief so that I can jealously guard every moment that we can for us to dialogue with each other, which is where we're heading as we go through this initial part of the process. The first person who will speak, and I'm standing behind her right now, the first person who will speak is Betsy Kohler, who is the Director of Cancer Epidemiology Services for the New Jersey Department of Health and Senior Services, and a person on whom we count for information very frequently, and so the phone back and forth does ring, perhaps some days more frequently than would be wished, but nevertheless, we appreciate that availability. The next person who will speak to you will speak on treatment, clinical care, and research of young adults with cancer, and that person I'm standing behind, Dr. Darlene Gibbon, who's the Director for Young Survivors Clinic, the Clinical Director of Gynecologic Oncology at the Cancer Institute of New Jersey, and an Assistant Professor of Obstetrics and Gynecology and Reproductive Sciences at UMDNJ, Robert Wood Johnson Medical School. Again, somebody who is well known in the state. And I'll move over one more step to introduce to you Dr. Jenny Grana, Generosa Grana, just to be more formal about it, who will speak on long-term effects and follow-up of young adults with cancer. And she's the director of the South Jersey Cancer Institute at Cooper University Hospital. Again, each of these people will bring something to this table that will help bring us to where we need to be when we dialogue later this afternoon. I'm going to ask Betsy to start us off.
Sure. I just want to give you a little bit of background about what we do at the State Health Department in terms of gathering the information that I'll present. The State Cancer Registry was established in 1979, and we collect information on all newly diagnosed cancers in New Jersey and tabulate, and we have a big database now of about, I think it's over 1.5 million records of cancer cases that have been diagnosed in New Jersey. We get reports from New York and Pennsylvania as well on New Jersey residents. And, you know, it's kind of hard being up here, being the data geek or the bio nerd or the statistics person, because I know people's eyes often glaze over, and we're often thought of as really just being cold and critical and just presenting the facts. And I want to speak to you and let you know that all the people in my office are there because we really care about cancer in New Jersey, and we're really working hard to do what we can in our part to help provide information that's useful to everybody. And we all have mothers and brothers and sisters and children that have had cancer ourselves, and we're not really just the data geeks. So that's my introduction. And I hope you can follow along in your handouts. I'm just going to walk through the graphs with you sort of informally. What we tried to do was show you how New Jersey compares to the United States in terms of cancers in young adults, and we took the age groups of, I think, ages 20 to 39 for our as our definition of young adult cancer. So on the first graph, you can see the pink line up at the top there is the United States. That's what the incidence of young adult cancers looked like for the last 25 years or so there, or more. And you can see that it rises there a little bit in the mid-90s and then comes back down. And New Jersey males is right there below it in the dark blue line. So it looks like New Jersey has probably had perhaps a little bit less cancer among males in this age group than the United States for many years, but we're really very close. And if you look down below, again, you'll see for females, we're very close to the pattern in the United States in general, perhaps a little bit higher for females, but pretty close. And I'm sorry, the greenish lines on both graphs represent the mortality or the death rates among these age groups from cancer. So even though the incidence rates or the occurrence rates are higher, the death from the diseases is lower. It's indicating a survival time that we're all aware of. If you turn the page, you can see here that for New Jersey and the United States, the survival looks almost the same. And for males, certainly it looks the same. And for females, New Jersey young women might have a slightly lower survival for all cancers combined than the United States. The one at the bottom of the page shows how the survival rates compare for other age groups in New Jersey. The children and young adults have better survival than those in the 40 to 64 year age group, quite markedly. This holds true for both males and females on the next page. And then I wanted to show you with the pretty pie charts on page 6, the distributions of the types of cancers that affect young adults in New Jersey. So the first one at the top is cancers in New Jersey males. You can see that cancer of the testis is one of the most common ones. NHL, which is non-Hodgkin's lymphoma, and Hodgkin lymphoma represent other large portions. There is a big portion of the cancers in the other category that are non-epithelial skins, which are really Kaposi sarcomas for both the United States and for New Jersey. And the distributions here, you can see that the pies for New Jersey and the U.S. are pretty similar. Next page is for females. Breast cancer being one of the most common in this age group, and I think if you broke this down a little further, you'll see that, of course, as women age, this gets more and more common, and we did start with women who were 20, so that's why I think this is probably a big piece of the pie here. Cervical cancer, also another big problem for this age group, and here you'll see that with both breast and cervical, we have slightly larger percentages than the U.S. Thyroid is also a common cancer in this age group for females, and is rising in New Jersey and other parts of the country. Just moving a little quickly here, this again shows the difference in cancer rates among the different age groups, the dark blue line being children. Rates among young adults are really fairly low compared to those in 40 to 65 year age groups, both for men and for women there. The last page shows us the cancer mortality rates, or the death rates. And here you can see that for children and for young adults, the mortality rates have remained fairly stable over the whole time period, while they've been declining in the older age groups. I think part of this is due to the different types of cancers in young adults versus the older adults, or not older, I hope they're not that old, but the older adults. So this is really where, again, we'd like to see some progress, is we'd like to see the mortality rates for children and young adults to decline the way they are in the older populations. And that's all I have to say.
Thank you. I should say we're going to hold questions, and those of us who work in the field know how important it is for us to be able to have this information, because the information can help drive our work, drive some of our understanding about where we need to next be. Let me stop for a second before Dr. Gibbons begins to talk. Those of you who aren't seated, please know there are seats down here, and you're perfectly welcome to join us. Be comfortable. Couple over here. Please feel free. We want everybody to sort of feel as comfortable as possible today. I had to remind myself this wasn't a formal day, so I wore a pantsuit instead of a skirt suit. Otherwise, I'd be into my formal head, so now I'm into my let's dialogue, less formal head. Okay, do we have everybody seated who wants to be? All right, so let me then move on and ask Dr. Darlene Gibbon to take us into treatment, clinical care, and research of young adults and bring us some information.
Thank you. So I've been charged today with the task of trying to explain the Progress Review Group, or PRG, in adolescent and young adult oncologies, and their recommendations as they relate to treatment, clinical care, and research in this age group. I think that to fully conceptualize how to design a research and clinical program for AYA cancers, we must look at the recurring themes throughout the PRG and how they impacted on the recommendations for implementation of the 4 of the 5 imperatives that have particular relevance to my discussion today. And those 4 imperatives are: ensure excellence in service delivery across the cancer control continuum as they relate to prevention, screening, diagnosis, treatment, survivorship, and end of life. Identify the characteristics that distinguish the unique burden of the AYA, or adolescent and young adult oncology patient. Provide education, training, and communication to improve awareness, prevention, access, and quality cancer care for AYAs, and to create the tools to study the AYA cancer problem. And we have to do this in 10 minutes. So why is this group underserved? I think progress in AYA oncology has been hampered because cancer risk and adverse cancer outcomes have been under-recognized for this population. And several closely interrelated factors may have contributed to the failure to improve the outcomes of AYAs with cancer, and can be broken down into what I refer as the 3 A's. The first is awareness. Cancer in this group goes under-recognized by the young individuals affected, the public, and even healthcare professionals. It is not widely known that cancer is the leading cause of disease-related deaths among adolescents and young adults, and diagnosis can be delayed because AYAs typically see themselves as invulnerable to serious disease or injury, causing them to ignore or minimize symptoms and delay seeking medical attention. Delayed diagnosis is also common because healthcare providers have a low level of suspicion of cancer in this population. And Matthew explaining that it took approximately 4 months to make his diagnosis of a brain tumor is unfortunately a very common story. The first step for the organizers of the PRG was to define who AYA patients are. This was undertaken by looking at empirical and observational research indicating that AYAs with cancer are distinguished by physiologic, developmental, and societal characteristics and lower or less improvement in survival that set them apart from younger and older age groups. To prioritize research and healthcare needs, the population was defined as being between the ages of 15 to 39. Knowledge about AYA clinical care needs is limited, and service development in the United States is embryonic. For AYA issues to be addressed effectively, the first critical step is broad acceptance of AYAs as a distinct demographic group with unique needs related to their age and stage of life. My second A is access. Access to care can be restricted or delayed in part because AYAs have the highest uninsured rate of any group in this country. AYAs with symptoms of cancer may see a variety of healthcare providers, including primary care and emergency room physicians, gynecologists, dermatologists, surgeons, orthopedists, and a variety of other specialists. Once seen, referral patterns for AYAs suspected of diagnosed cancers vary widely. They frequently fall into a no man's land between pediatric and adult oncology and may be treated by pediatric, medical, or other adult oncology subspecialists. Most AYAs are treated in the community rather than in cancer centers, but a robust community oncology and primary care infrastructure currently does not exist to enable patient data collection and aggregation that would support research efforts. In addition, contact with many AYA patients is lost following treatment complication, collection of late effects, and outcome data is in this highly mobile population. My last A is advances. Research on AYA has been further constrained by their exceedingly low participation in the relatively few clinical trials available to them. Poor understanding of patient and tumor biology that distinguishes cancers in this population has contributed to minimal advances in treatment. Inconsistency in treatment and follow-up, coupled with insufficient research data, has prevented the development of guidelines for treating and monitoring with AYAs and cancer, and there few tools exist to measure the efficacy of treatment and psychosocial interventions delivered in diverse settings. So looking at those 4 imperatives that I explained to you before, let's break them out into research, and let's break it out into clinical management of these cancers. So first we're going to deal with research, and I think that the 2 topics that have particular relevance to that are identifying the characteristics that distinguish the unique cancer burden in the AYAO patient, and second, to create the tools to study the AYA cancer problem. More robust research efforts are needed to better understand tumor and human factors which likely interact and lead to this problem. These factors may be genetic, metabolic, hormonal, environmental, pharmacokinetic, social, and other human factors that affect disease susceptibility. High priorities include basic and other biological research on aging and patient-host-related factors. In addition, factors that characterize and account for disparities experienced by AYA cancer patients and survivors are understood only in broadest terms, and therefore research is needed to elucidate in detail the factors contributing to underservice and poor outcomes among AYAs as a whole and among racial and ethnic subgroups within the AYA population. Among the 703 active, applicable, NCI-sponsored trials, only 26 phase 3 trials have no age limitations that exclude a portion of the adolescent and young adult patient population. And currently, there are no phase 3 melanoma, hepatic cancer, or thyroid cancer trials accessible to this group. And you saw from Betsy's data how many patients are afflicted with those cancers in this age group. More clinical trials designed specifically for AYAs are needed, as are more trials that include AYAs in the accepted patient age range. When AYAs are enrolled in trials that include a wide age range, separate analysis and reporting of outcomes by age cohort should be conducted whenever possible. Research is needed on interventions to prevent or ameliorate the sequelae of cancer therapy. The existing research infrastructure is inadequate to support needed AYA-focused research. Appropriate research tools to enable such studies must be developed if they do not exist, and strengthened if potentially useful infrastructure is already in place. The most pressing needs are to create a prospective database on all AYA cancer patients, increase the number of annotated AYA tumor, normal tissue, and other biospecimens, create or modify assessment tools specific to AYA cancer issues, improve grant coding and search term standardization, and expand the number of clinical trials appropriate and available to AYAs. A rather large task. If we look at the 2 imperatives with respect to treatment and clinical care, they would be provide education, training, and communication to improve awareness, prevention, access, and quality cancer care for AYAs, and ensure excellence in service delivery across the cancer control continuum. The AYA's PRG recognized an urgent need for a variety of education, training, and communication activities to raise awareness and recognition of the AYA problem, both at a public and professional levels, as a first step towards increasing national focus and resource allocation to address the AYA cancer problem. To be effective, all education, training, and communications must be culturally appropriate and delivered by individuals who are culturally competent. Current healthcare provider training programs generally do not address AYA-specific issues, resulting in poor recognition of AYA's cancer risk and inadequate response to their medical and psychosocial needs. Core competency curricula are needed for inclusion in appropriate initial training and continuing education programs to ensure that all providers who work with adolescents and young adults have the requisite understanding of the cancers that either peak or occur more commonly in this age group. It's targeted education to raise referring physicians and medical oncologists' awareness of the potential benefit of AYA-relevant trials means a means to improve patient outcomes through increased participation. The AYAO-PRG urges the implementation of two principal strategies to improve service delivery to AYAs with or at risk for cancer and ensure excellence in care across the cancer control continuum. First, standards of care for AYA cancer patients must be developed and disseminated. No consistent standards exist for delivery of cancer-related care to AYAs, and the evidence base needed to establish standards across the continuum of care is weak. Standards should be based on available evidence, best practices, and expert opinion, with the expectation that they will evolve as the evidence base matures. Standards are dynamic and must be updated as advances in care are achieved. Excellence in care may vary not only by cancer diagnosis, but also other variables, including age and gender, race, ethnicity, culture, socioeconomic status, access to source of care, and insurance status. And these must be addressed to meet the complete spectrum of patients' needs. Second, establishing, disseminating, and reinforcing standards of cancer care for AYAs will require the ongoing and concerted collaboration of a diverse array of stakeholders. Healthcare providers, research sponsors, investigators, regulators, insurers, and patient advocates should expand existing collaborations and establish a national network or coalition committed to improving the quality of life and outcomes of AYAs with cancer. New AYA-specific clinical programs should be developed based on current knowledge and successful existing programs. These AYA programs should be evaluated rigorously through a program of health services research to strengthen the evidence base and guide future program development. Despite the needs for research, the PRG concurs with the consensus that has emerged among healthcare professionals, healthcare organizations, patients, and advocates that services for AYA should be based on a patient-centered model of care. Such a model includes system-related elements: rapid access, competent assessment, timely and accurate diagnoses, evidence-based treatment, access to clinical trials, late treatment effects, psychosocial, and other support. AYA patients need access to oncology centers of excellence, access to clinical trials, and a means to obtain appropriate counseling, peer support, and patient navigation or health coaching. I have several of the goals that were set forth by the PRG particular to this group. I have listed out, and I thought I could just mention them briefly so that we have a basis, because I think that these are goals that we can achieve today, or at least springboard and try to increase or improve care for AYA cancers in New Jersey. And just briefly, some of them, these were set forth by the PRG. To establish AYA as a distinct group of cancer patients based on unique needs and issues, institutionalize the definition and gain broad acceptance among stakeholders in AYA care. Focus on increasing referring physician and oncologist awareness. raise awareness of AYA cancer issues as a first step towards increasing national focus and resource allocation to address the AYA cancer problem, provide target education to patients, families, caregivers, and the public about AYA cancer issues, educate multidisciplinary providers who work with AYAs to improve referrals and services to this population, elucidate unique biologic characteristics of AYA cancers and AYA patients that affect disease outcome in this population, elucidate AYA life stage developmental characteristics that influence care seeking, adherence to treatment, and medical and psychosocial outcomes. Target malignancies that have the greatest potential impact on the AYA cancer problem for increased clinical trial involvement, including sarcomas, lymphomas, breast cancer, colorectal carcinoma, germ cell tumors, leukemia, malignant melanoma, bone sarcomas, and brain tumors. Create a large prospective database of AYA cancer patients to facilitate research on this age group. Increase the number of annotated specimens to support research progress. Expand clinical trials for AYAs to increase treatment choices and accelerate treatment advances. Develop, evaluate, and disseminate standards of care for AYA cancer patients and survivors to improve outcomes. Establish a national network or coalition of providers and advocates seeking to achieve a standard of excellence in AYA cancer care. And identify and ameliorate health disparities experienced by AYA cancer patients and survivors. We have a lot of work to do.
Quite a roadmap. Thank you for that. Another moment for anybody else who needs to take a seat to take the seat, because I notice some people are still standing and perhaps they're choosing to. Then we will proceed. As I said, Dr. Jenny Granner will speak to us on long-term effects with young adults, and so please do.
Thank you. I was very touched by what was said earlier about living with, through, and beyond cancer. And I think that's really, I'm talking about beyond cancer, but the reality is that we deal with young adults in each of these facets of their treatment. In addressing the issue of long-term follow-up and sequela of treatment, I think we need to focus on several things, and I think the issue is that it is an evolving and still rather poorly understood field. The issues that need to be addressed are, what are the late effects of treatment? And I'm going to go through briefly what the late effects of chemotherapy, radiation, surgery, and we have to understand that many of these are combined when we treat young adults. What are the risks of recurrence that these survivors face, and are these risks of new cancer, and are these cancers due to the fact that they happen in association, or are they cancers that happen because of a hereditary risk? So a young adult needs to be dealing with all of those issues. We also need to think about the impact of the young survivor's diagnosis on their family. Again, is there a hereditary component? Forget all of the issues that cancer in a young adult poses for themselves and their family in terms of dealing with the financial, emotional, and other elements of the disease. But what does it mean in terms of risk for other family members and preventive strategies that need to be addressed? I'm going to come back to each of these points because I think what was said earlier about the things that need to be put in place for treatment of the young adult also need to be put in place when we think about follow-up of the young adult. And this really comes to the idea of the challenges facing our healthcare system. The first challenge facing our healthcare system is the fact that we lack a lot of information about the sequela that we are concerned about. We have collections of data, not good collections of data, that are guiding us, but when young adults lose their hearing, is there enough information out there that it should be widely recognized? We need to be collecting this data better. We need to get a better handle on risk. We need to get a better handle on prevention and treatment strategies, and it's just not out there. Who follows young survivors? It would be ideal if they were followed by an oncology team that was multidisciplinary in nature, that included psychology, medical oncology, surgery, radiation therapy, and each would bring the strengths of their field to bear on the follow-up of young adults. But the reality is that we have a medical oncology system that is at times overwhelmed, and often too focused on cancer as the only issue that these individuals are facing. the primary care team, should they be the ones that follow young adults? That would also be ideal if we could get the information to the primary care team, but often these individuals don't have the specifics of the treatment and the specifics of the toxicity that need to be addressed. More and more, we're seeing the development of survivors clinics. And again, that would be an ideal venue for this population because it is a clinical setting in which reproductive issues, long-term toxicity issues can be addressed. Unfortunately, by the sheer intricacy of survivors clinics, few of those are available. Having said that, what are the late effects of therapy that survivors need to think about? The late effects of therapy pose risks that often are dependent on the type of treatment, the tissue of the body that was treated, and the modality with which the treatment was done. There are very significant differences in toxicity if we're looking at radiation, chemotherapy, in particular the different chemotherapy agents, or surgery. And when you combine these modalities together, oftentimes the toxicity becomes significantly greater and the late effects become significantly greater. It often depends on dose of radiation, dose of chemotherapy. It depends on the combination that was used, and it also depends on the time-specific nature of the treatments. Again, oftentimes these are combined and additive. There was a wonderful article that, as I was, Anne-Marie called me about this presentation, just timely, that an article came out addressing the long-term solid cancer risk among survivors of Hodgkin's lymphoma. Now, Hodgkin's lymphoma and testicular survivors are probably the most well-studied population. They're curable diseases. They have long tracking records. But if you look at this article that was published on the Hodgkin's population, it becomes very clear that the individual's risk of second cancers are quite high. For women, the highest risk is breast cancer. It's bilateral breast cancer. The risk is dependent on whether greater if you had radiation and chemotherapy. It depends on age. If you were diagnosed under 30, you have a significantly greater risk. And again, this is just now an evolving field, and we need to begin to get the message out there that these young women need to be screened with mammography at much younger ages. There's also increasing data that cardiac risk factors in the Hodgkin's population are much greater. We need to be thinking about preventive strategies, cholesterol lowering, lifestyle altering interactions, and better screening for the Hodgkin's survivor because of their risk of cardiac toxicity and cardiac risk. So again, papers such as this are making their way into the oncology community. But papers such as this are not making their way to the primary care community, and it is the primary care provider that often follows many of these survivors who no longer go to the oncology center for their follow-up. So I think there's really interesting data that is coming out. Why does information about late effects why is this so important? It's important because we may be stuck with the effects, the late effects, but there may be many modifiable factors that we need to begin to address. So for example, how do we screen individuals? With what modalities? In young women with Hodgkin's who've had radiation, do you include mammography and MRI? In other patients, do you use different modalities for your screening? When do you begin your screening? Do you begin it at the usual age in which we screen the population, or do you begin younger? How do we begin to study lifestyle change and the effect of lifestyle change? It's nice to think that potentially lowering cholesterol may alter cardiac risk in these populations, but we don't know that for a fact. And again, we need to begin to study some of these factors so that we can make intelligent recommendations to our population and really guide them through the process. Are there exposures that they need to avoid? Yes, clearly if you've had testicular cancer and you've been exposed to bleomycin, tobacco should not be anywhere near your mind frame. But is that information out? Are we doing enough to alert survivors about potential risks of different exposures and how those exposures may be dangerous to them? When we think about the late effects of treatment, we need to think about fatigue, pain from their surgery, pain from the sequela of ports that have been in for chemotherapy, pain from the radiation, many types of pain. We need to think about the menopausal symptoms that women have. If you're 30 years of age and you've just been put into menopause because of your treatment for breast cancer, it's not a particularly pleasant experience to deal with vaginal dryness as you would if you were 50 years of age, or to deal with the hot flashes and night sweats that can drive people crazy. So these are issues that are important. Reproductive factors become a huge issue when we're dealing with a population of this age. We heard about the fact that he only later found out that he was fertile. Many of our patients are not fertile, and we have to walk them through options around fertility because there are many things that can be done prior to their treatment and other things that can be done following their treatment. For the people that were treated earlier as children and now they're young adults in follow-up, what are the growth effects of their radiation therapy to the spine? What are the growth effects of limb irradiation? Again, we need to educate the public better about these things. And finally, end organ dysfunction. You heard mentioned that there is lung toxicity, cardiac toxicity. There is. Almost every organ in a particular person can be affected. We have pulmonary toxicity from some of our chemotherapy drugs, such as bleomycin and Cytoxan. We have cardiac toxicity from adriamycin. That's a common agent for leukemia and sarcoma. Herceptin, now the drug of choice for many young women with breast cancer, has cardiac toxicity. We have neurotoxicity from the platinum compounds that some of our patients receive and from the drugs that are given for other diseases as well. Toxicity to the kidney is not unusual in patients who have had treatment for testicular cancer. And also in patients with testicular cancer, vascular toxicity. Some of these agents have significant effect on the vascular system. So again, as we focus on the issues that patients are experiencing long into their survivorship mode, we need to be aware, and we need to make other primary care providers aware that each of these areas need to be addressed and followed and assessed. Let me just talk for a moment about disease recurrence, because that was something that was raised earlier. Every cancer survivor has one compelling fear, and that is risk of recurrence. When will it happen? Will it happen 2 years later, 5 years later, or with some breast cancer survivors, 10, 15 years later? And again, this is something that they deal with, but it's something that their healthcare team also deals with. As we think about other cancers, are they going to be at risk for other cancers due to their treatment, or are they going to be at risk of other cancers due to their hereditary factors? If you're a young woman diagnosed with breast cancer and you have breast cancer due to mutations in BRCA1 and 2, you have an increased risk of cancer of the opposite breast. You have an increased risk of ovarian cancer, maybe melanoma. So again, as we think about cancer in the future for these individuals, we need to think about recurrence, yes, and monitoring for recurrence, but we also need to think about new cancers and preventive strategies for some of those new cancers. I think the key is that this is an evolving field, and we are all learning as we go. It is not a field that is rich in literature, and our hope is that we get there, that the clinical trials are done to guide us in better treatment selections, in less toxic treatment selections, but also that trials and data accumulate that can guide us in the management in terms of long-term follow-up of these patients.
I thank you. I want to thank the panel for being so responsive. We have held so tightly on the time frames, and so I apologize and thank you. We're going to shift over, no questions, time to mull what they've said. We'll get our new group of panelists up, and they'll be back again. Shall we just show them some appreciation for their having